Dear colleagues, next presentations will be from Mariusz Smigiel. Mariusz Smigiel, famous European endoscopic spine surgeon, my teacher, and not only my teacher, I think a lot of Ukrainian spinal surgeons thankful for Mariusz Smigiel.
Thank you. I would like to tell you about problems and complications when we encounter during transforaminal lumbar discectomy. I do outside-in method using MAXMORE instruments. So the goal is to go inside the spinal canal. And the transforaminal method consists of two parts. The first one is under C-arm control without endoscopy, and the second part is endoscopy. The most common approach is from tip of SAP on lateral view to the upper angle of the vertebra, and on the lateral, on AP view from tip of SAP to the midline. Of course, the approach depends on location of the herniation. And what are the rules that facilitate us to avoid damaging of the neural structures is local anesthesia and analgosedation, usually. I don't cross medial margin of pedicle line by sharp Tomshidi needle. Usually from L3, L4 level and above, I use only blunt Tomshidi. And what is the most important, I think, I remove only the tissues that I see. In my presentation, I'm talking about 953 patients. I operated them between 2012 and 2023. Of course, it is obvious that when we started with new method, the problems occur. And the first problem is placing the needle. So I recommend to start transforaminal blockade, and it will help us to understand the anatomy. Proper anesthesia. Usually I do surgery in analgosedation. So for the soft tissues I use lignocaine, for facet joint 2% of lignocaine. But important is cooperation with anesthesiologists. And anesthesiologists use propofol, fentanyl, and midanium. Because on the one hand, we want to have comfort that patients doesn't move on the table. And on the other hand, we want to have information from the patient when our instruments are close to the nerve root. What is important and what is difficult that we should have three-dimensionally thinking, because we only have two pictures, lateral and AP. And when you compare the wave on lateral view, it is short, on AP view is longer. And this is why we should imagine our way to spinal canal. It is example bed approach. You can see on arrow points the bed approach to the disc, not to the herniation. We have sometimes problem with key wire, but it is easy to remove the key wire through the working sleeve. And at the beginning, we have problem with recognizing the structures, because we see the same anatomical structures, but from a different angle and from a different side. Yeah, so it is lateral view. Twice it happens that I found steri drape in the operation field. So when we do too small incision, our drill can push the drape inside. And of course bleeding. it's a normal problem, so we can wait for a while, turn working sleeve, increase the pressure in the pump, use radio frequency, or sometimes give tranexamic acid intravenously. And for far migrated herniation, we can do two approaches. Complications are very rare, but they happen. And I divided the complications between two hospitals because in 2018 I changed the hospital. So you can see about the numbers. Only once I noticed epidural hematoma, treated conservatively. I had two cases, persistent and heavy bleeding because of damaging of spinal artery or venous plexus. So I had to insert the spongiofilm to stop the bleeding. Twice I broke the articular process, but it was easy to remove the fragment with punch. Twice I damaged the nerve root. It was at the beginning of my gaining experience, and patient was too deeply anesthetized, and I didn't recognize the nerve root. Happily, before surgery, patient had paresis. So nothing changed. Only once I damaged the dura because our instruments are safe. Our drills we use are safe. So it means that because they have a blunt tip, and when we push the dura, it moves medially. But in this case, the patient was after total facetectomy, and dura was immovable because of a scar tissue. So I ordered 2 days stays in the bed, and nothing happened. Dysesthesia, it is abnormal sense of the touch. Usually it is a pain, and it is an example. Before surgery, patient had 2 pieces of herniation, 2 sequesters in the foramen and out of the foramen, and because of the pain, 4 weeks after operation, I ordered control MRI. As you can see, that the nerve root, the exiting nerve root is thickened and swollen. Only once I had spondylodiscitis. After 1 month from endoscopy, patient fell down and started feel very, very severe pain. It is on the below is MRI before second surgery. I didn't expect the spondylodiscitis, but during the surgery, each tissue was bleeding, and this is why I ordered laboratory tests and then antibiotic therapy through 6 weeks. And half a year ago, I had a young girl, 17 years old, after 3 operations during 1 year in another hospital, twice microdiscectomy with damaging of the dura, with paresis, and the last operation was back jack, interspinous implant. And it is MRI before surgery. I offered her endoscopy to remove herniation. And I found massive scar tissue, and I decompress exiting and traversing nerve root. I was very proud of this operation. But just after endoscopy, she felt severe pain and started screaming. And unfortunately, paralysis of the foot increased. So after 5 weeks after endoscopy, paralysis still exists, and still exists pain below the knee. It is control MRI. After my endoscopy, I recommended her to wait before the next surgery, because the next surgery should be fixation, I think, and maybe open, I don't know, open or endoscopical decompression. But I don't know what is going with her, because she came to me only 4 weeks after operation. And recurrent herniation, maybe it is not complication, but it is a normal statistic. The problem in transforaminal approach is that we cannot check the intervertebral space, because we go obliquely to the spinal canal. And on L4, L5, and L5S1, we have limited range of motion with working sleeve. So I have 8% of recurrent herniations, but what was interesting for me, that more than 80% of reherniation is during 1 month after operation. And we should know that there is steep learning curve in transforaminal method. It is not free from complications. We should, during the procedure, attention is recommended. And we should always analyze the MRI to determine the access and have a plan for modification. And high percentage recurrent herniation is due to impossibility of checking the intervertebral space. Thank you.
Thank you very much, dear Mariusz. Maybe somebody has questions? Yeah.
Thank you so much for supporting the Ukraine physician in this field. And only one question for you. Have you ever performed electroneuromyography as evidence for radiculopathy of lumbar spine? Thank you.
Usually I don't order electromyography, but sometimes patients are treating by neurologists, and usually neurologists ordered EMG. Yeah.
I think it was about this last patient.
Okay.
Very careful.
Yeah, but it would be important if I could compare before and after. So I didn't have before, so I didn't order after surgery.
Thank you very much.